Howard asked me to talk to you this morning about some of the consequences from a digestive standpoint and nutrition standpoint of surgery for pancreatic cancer. As he pointed out, there are really 3 different operations. He didn't mention the second one because it's rarely done, but all of these involve a resection of a portion of the pancreas and/or surrounding organs for cancer. I'm not going to dwell on pancreatic surgery for non-malignant disease. That's a whole different topic. But all of these surgeries require a variety of common things. And they are an anastomosis of a portion of the pancreas or a sewing over of a portion of the pancreas. And in that regard, the surgical risk from a complication standpoint has to do with leak or fistulas, the development of a problem at the place where the pancreas is sewn into another spot or is sewn over. It's interesting that it's less common in patients who have chronic pancreatitis because they oftentimes have a much more fibrosed, hard gland that when you put sutures in it is perhaps more likely to hold than the soft tissue of a less inflamed organ. We're going to dwell on the Whipple procedure, and that's because taking out the tail of the pancreas rarely produces significant metabolic, nutritional, or digestive problems. But taking out the head of the pancreas, or in other instances, this operation is done for removal of tumors involving the distal bile duct or the duodenum, involves a major change in the physiology and the anatomy of the gastrointestinal tract. And so I'm going to show you some slides that Howard has already shown, but perhaps embellish it just a bit. And that is that you can see this is the potential area that has to be removed. These are the 3 different anastomoses or connections that have to be made. You've taken out the normal connection for the bile duct, so now you got to sew it into this portion of the intestine. You've cut away the gland, the head of the gland of the pancreas, so now you got to sew this pancreas into the intestine here. And in the standard Whipple operation, you've taken away the antrum of the stomach, and that needs to be sewn in here. And it can be done, and there's a slight variation that Howard didn't show, and I don't think it's relevant to our discussion. The pancreas can be sewn in end to side or end to end here. The pyloric preserving Whipple operation preserves the antrum of the stomach, and I'll go into the reason why in a few minutes, but otherwise is essentially the same operation. So you can have problems anywhere along the line with regard to these hookups, and we'll get into what some of those problems can be. So there are postoperative issues that are common to all of these operations, and they can be divided into the early and almost the common or expected ones that from a surgical standpoint, it's not unusual to see, and they're generally not ongoing. They can be more serious early complications that require intervention, and then there are late or ongoing issues related to the nutritional process and the nutrition and the digestive process of these folks. Now remember that with any operation of this type or a major abdominal surgery, there's a transient period in the postoperative state where the gut stops working. And this is associated with what we call an ileus. This generally is short-lived and is not a cause for ongoing problems. But for reasons that are not always clear, there is the potential for a delay in the way the stomach empties after this operation. And this can occur in as much as 15 to 25% of patients. For a while, there was some concern raised that this was related to the pylorus preserving operation, but when these folks were looked at and statistically compared, there was no significant difference. And while most of the time it's self-limited, occasionally it is prolonged. One of the issues that was likewise suggested was the type of hookup that was done between the stomach and the intestine. There's something called an anti-colic as opposed to a retrocolic operation. Now the colic refers to the colon, and so I don't have a fancy picture that Howard has to show you this, but think for a minute as we imagine this, that the anastomosis or the hookup is done either in front of the colon or behind the colon. And if it's done in front of the colon, there's potential for an angle to exist, whereas if it's done behind, it's more of a straight shot. So there was a thought that by doing it retrocolic, there was a lower incidence of this gastric emptying problem. You can find literature supporting that. You can find literature that says there's no difference, and I'll leave it to the surgeons to decide. But I think for the vast majority of cases, nowadays it's done retrocolic. Is that correct? No, antrocolic. What do I know? Thank God I'm not a surgeon. Okay. If this event occurs, though, and patients are not emptying well, then you have to put a tube down and suck the juices out so they don't vomit. And there's an interesting paper that was presented a long time ago in the Annals of Surgery that showed that erythromycin in small doses, which is an antibiotic that, by the way, also has pro-motility effects. It increases gastric motility and emptying. Actually can be used intravenously during the postoperative phase and reduce the incidence of this postoperative gastric emptying dysfunction. At least in this paper, it reduced it from 57% to 14%. So I don't think we routinely do that, but it's something to bear in mind, and certainly can be used along with other pro-motility agents if need be in the event of poor gastric emptying. What needs to be looked at, however, if it's prolonged, is whether or not there is a leak or a fistula, because that can be the source of the problem. And if it's not detected, that can lead to high incidence of complications and even mortality. So what about leaks or fistulas? Rarely it can occur where the bile duct is hooked up. It can occur where the pancreas is hooked up. It's actually less common with cancer operations, from what I've been able to find, than it is when these surgeries are done for chronic pancreatitis. Early detection is important because you have to drain it if need be. And from a surgical standpoint, and again, this is beyond my expertise, but I'll relay the information I've learned about it, is that when the anastomoses are done, instead of taking the whole thickness of the pancreas and hooking up to the whole thickness of the wall of the intestine, you hook up the pancreas to the lining side, the mucosal side of the intestine, and that theoretically is associated with lower risk. Right? Wrong? Does it matter? Howard, tell me. See? Told you. That's an internist view of a surgical procedure. So, all right, what about the long-term issues? And this is really more of what I've been asked to talk about. Weight loss, bile duct obstruction, problems related to the functioning of the gut, problems related to what we call pancreatic exocrine function. Now, the pancreas, remember, has two major functions. It makes enzymes that are used in the digestive process, and it makes insulin, among other hormones. So there's exocrine, which is the digestive process. There's endocrine, which is the insulin-related processes. There are problems that are potentially related to mineral and vitamin absorption and overall nutritional weight loss issues. Weight loss is almost universal. Folks who have this disease may go in feeling fairly well, but they're going to have a major operation. There's going to be a major hit to their alimentary function. And postoperatively, virtually all patients will lose weight. This will usually reach its nadir at about 3 months, and most patients who are otherwise doing well will regain their basic weight within a year. Now, you have to take all of this into consideration when remembering that this is under the assumption that they're not ill with recurrent disease and getting vigorous therapy for that, because that obviously has a potential to influence any of these factors nutritionally and digestive function. But for the most part, even those who are receiving adjuvant chemotherapy and doing well will regain their weight at a year. Bile duct obstruction can be caused by a variety of things. You can have a stricture where the anastomosis or the hookup has been made. Remember that limb that you saw that was brought up and where everything was sewn into? That is called the afferent limb. Afferent, it means that there's stuff coming from that toward and going beyond where the anastomosis is with the stomach. Afferent means from, efferent means going away from. So think of it in those terms because it's important. There'll be a test on this at the end of it. The afferent limb can twist, can kink, and occasionally lead to the consequences of a backup and the inability of the bile duct to empty well. Rarely you'll get stones in the bile duct. What's the importance of it? Well, bile is needed and is used in the digestive process, and if you make less of it or you have less of it in the gut, the mixing of and the absorption of fats is going to be significantly impaired. So aside from presenting with potential jaundice or pain or what have you, it also has a potential effect on the absorptive and the digestive process. Dumping and diarrhea. This is a term that was used and was as a problem that was seen much more commonly years ago when we used to have a lot of patients undergo surgery for ulcer disease. One of the common operations for ulcer disease was to take out a portion of the stomach and hook it up to the intestine, not too differently in some ways than we see here with this operation. And the stomach, as Howard mentioned, is supposed to empty at a metered, regular rate. If you don't have the pylorus, if you don't have antrum, the stomach is going to empty much more rapidly into the intestine. And as a result, there's a tendency for diarrhea. There may be a tendency for poor mixing and poor absorption and poor timing between the period of time when the food and the nutrients enter the small bowel and gets absorbed, and when insulin is produced. So as a result, you get a rapid rise in blood sugar. That triggers an insulin release, but by the time the insulin comes around to do its job, the sugar's down and gone, and so you get hypoglycemic. So you can develop a problem related to low blood sugar and the symptoms related to that. Diarrhea, lightheadedness, cramping, bloating can all occur. Now, they can also occur even with the standard pylorus preserving Whipple, but less commonly. And that's the rationale for preserving the antrum and preserving that pyloric sphincter muscle. How do we manage it? Smaller, more frequent meals. Separate the liquid from the solid portion of the meal. In other words, eat the solid portion. Don't drink while you're eating. Wait a half hour. Have something to drink later. And avoid simple sugars. Simple sugars get dumped in quickly. They get absorbed, trigger an insulin release. They're gone. The insulin's now high. Blood sugar goes down. So dietary matters, and we'll hear more about that, I'm sure, after my talk. The other problem that can occur in this afferent limb issue is an overgrowth of bacteria because of poor emptying. And again, bacteria affects the digestive process. If they're too high, they cause a fermentation reaction. The bacteria starts to digest the sugars and produce a lot of gas and cramps, and can be readily treated with a short course of an antibiotic for 10 days. One of the other things that can occur that can affect and lead to diarrhea is the development of problems related to chemotherapy, and Lee will talk about this, I'm sure, as well, and that is that you can have a higher incidence of an infection with a bacteria called C. difficile. This is most commonly an organism that thrives after antibiotic usage and can lead to cramps and diarrhea, but it can occur also in association with chemotherapy. You can get an inflammation of the lining of the intestine due to the chemotherapeutic agents, which is called mucositis, and that can lead to diarrhea. And lastly, don't forget that because you had pancreatic cancer and a Whipple operation doesn't mean you can't have other problems. Lactose intolerance can occur, and you should think about that. And I've diagnosed celiac disease in 2 of Howard's patients who had Whipples for pancreatic cancer and had this ongoing diarrhea all of a sudden really worsened after the Whipple operation. And lo and behold, they had sprue. And so we treated them with a gluten-free diet, and they did great. What about pancreatic exocrine deficiency? Now this is, again, pancreas makes enzymes used in the digestive process. They make enzymes that break down fat, break down sugar, complex carbohydrates, and break down protein. What are the consequences of inadequate pancreatic function? Cramping, bloating, flatulence, diarrhea, steatorrhea, which means the inability to absorb fat and excessive quantities of fat in the stool. This results in weight loss. It can result in the malabsorption of fat-soluble vitamins like vitamin A, D, E, and K, and actually can also result in malabsorption of vitamin B12. So let's talk about some of these. How commonly do we see this? Now, traditionally, it's been said you don't lose or become symptomatic from pancreatic exocrine insufficiency until you've lost 90% of the functioning of the gland. But there are more sensitive tests than waiting for the patient to show up 30 pounds underweight and with profound fatty diarrhea. There's a test called an elastase level, which is a measure of an enzyme in the stool. And it's interesting that when you look at patients who come with the diagnosis of either cancer or chronic pancreatitis, 1/3 of them already have evidence of elastase deficiencies or elastase levels in the stool that are below what's considered normal. Pre-surgical, before they've had their Whipple. Post-surgical, if you look at the folks who were normal at the outset, they continued even without any problem related to the anastomosis, without any obstruction to the duct or anything like that, they continued to drop their elastase levels. And at 2 years, about half of them have low elastase levels. Those who started out abnormal remain so. They don't get any better at 2 years. Overall, more than half the patients who've had a Whipple operation will have low elastase levels in the stools, even with everything being fine from an anatomic and surgical standpoint. And Bill Traverso was up at Virginia Mason Clinic, published a paper several years ago raising the issue, should all patients be put on pancreatic enzyme supplements following the operation, regardless of whether they manifest evidence overtly of failure to absorb fat or have malabsorption issues or maldigestion issues. And there's no solid answer to that, and we can talk about what to do if, in fact, you decide to do that. You need to provide what amounts to only 5 to 10% of the equivalent amount of enzyme that the pancreas makes in any given day to overcome this effect. And so 90,000 USP units with a meal. If there's 2 kinds of pancreatic enzyme supplements, those that are enteric coated to prevent degradation of the enzyme by gastric acid, and those that are not enteric coated. For those that have had a pylorus preserving Whipple, which nowadays counts for the majority, we recommend the enteric coated so that it has more efficacy when it gets into the intestine. It's not going to have been broken down by gastric acid. 2 pills per meal, usually best to give 1 when starting the meal and 1 halfway through the meal, but to some extent this is predicated upon how big the meal is, how fast somebody eats, and it's not really that important. And for snacks, 1 pill is probably enough at a time. There are no side effects from these drugs. The only side effect is whatever it costs out of pocket to buy. But from the standpoint of what do you have to lose? 0. What about vitamin supplements? Vitamin D, especially 25-hydroxylated vitamin D, which is better absorbed. A low-fat diet if necessary in the event of significant difficulties with steatorrhea. And if somebody appears to be resistant and continues to have what looks like malabsorption and they're not responding to enzymes, think about that bacterial overgrowth phenomenon, because that can contribute to it as well, and that can be treated readily. What about the other big problem, and that is endocrine function of the pancreas? What about diabetes and this disease, and diabetes and this operation? It's interesting that anywhere from a third to a half of those patients with pancreatic cancer manifest diabetes. We always talk about trying to limit the extent of the gland that's removed in any operation dealing with the pancreas, because we're fearful of creating an insulin-dependent diabetic. It's not so rare even without it. They're not all insulin requiring, but it's not a rare problem. There's even a school of thought from a research standpoint that treating the diabetes, trying to use drugs that promote more insulin production, or trying to use drugs that promote insulin efficacy, does something to the islet cells in the pancreas, and maybe in some bizarre way actually promotes the development of pancreatic cancer. And there's a school and an area of research that's actually looking at this. It's interesting also that if you look at new onset diabetes, it's not rare to have those folks then develop pancreatic cancer within a few months. And there's been some sentinel articles out there in the last few years that have looked at this. It's not, from a cost-effective standpoint, reasonable to say if somebody develops diabetes, they better get a CAT scan to see if they have pancreatic cancer, because the yield will be relatively low, and you can't justify that cost. But of those people who have pancreatic cancer, if you look back, 4% of them develop diabetes within a month of the time of its presentation. 21% at 5 years will have had diabetes. And if you just measure fasting or 2-hour postprandial blood sugar levels, maybe not overt clinical symptomatic diabetes, more than half of the patients who have pancreatic cancer will have and have had this operation will have it by 12 months. So when diabetes develops, it's usually type 1. You usually need insulin. But it's a little different than the typical type 1 diabetic. Most common type 1 diabetic without obvious pancreatic disease has a problem related to production of a hormone called glucagon. So there's an imbalance. There's maybe not enough insulin, or there's too much glucagon. Glucagon causes the blood sugar to go up. Insulin causes the blood sugar to go down. And therefore, there's an imbalance and creates the problems with regard to blood sugar. In this disease, because of the injury that's present, not only do islet cells that produce insulin perhaps potentially decrease in number or in efficacy, but islet cells that produce glucagon, which is another hormone that the pancreas makes, may also go down. So what does that mean? That if you give insulin, they're more likely to become hypoglycemic. There's not this counter effect. So you got to be careful. You got to use smaller doses and monitor them very, very carefully. Mineral deficiencies. Remember again the diagram of the operation. The duodenum is gone. That's taken out. We've brought up a lower portion of the small intestine and hooked everything in there. The duodenum is an important organ, important part of the small intestine. It absorbs certain things. Iron, calcium, magnesium. So while these are not exclusively and only absorbed in the duodenum, they are to a large extent absorbed there. So without a duodenum, there's the potential risk of deficiencies of these vitamins, and they should be monitored. And there's another phenomenon that we see, and I see all the time, and that is, you all heard of the purple pills, Prilosec, Zantac, all of the other proton pump inhibitors that are used so commonly for acid reflux disease. Well, guess where they're primarily absorbed? Duodenum. So we have patients who have reflux, who get an ulcer, etc., and they're given one of these drugs that's just not doing as well. I can't understand it. Why aren't they responding? Because to some extent, the absorption of these drugs are diminished as well following this operation. So in summary, there are lots of postoperative problems that vary in severity and in frequency, but the vast majority of them are identifiable and controllable. It's important, as you will hear from one of our speaker after Dr. Rosen, to look for nutritional issues and deal with them as they arise. The patients who present with different starting points. Those who are already quite ill and have lost weight versus those who have an incidental finding on a CT scan that leads to their diagnosis and early intervention. And so that has a great effect on their postoperative problems. Now, Dr. Reber mentioned this, and I'm going to emphasize it. The skill of the surgeon, the experience of the surgeon, the ability to do the proper techniques, anticolic, not retrocolic, like I would have done, is hallmark. It is crucial that this operation be done by centers that do a lot of them, because it is still the most challenging operation in general surgery, and it still is the one that has the potential for enormous complications and even death. So it's important that these folks be operated on by people who are skilled and capable of doing the operation. This is no walk in the park. This is a big operation. It has its consequences, but it's not being done for a simple cold. Serious disease, and it requires serious treatment. Thank you.